Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The Will to Go On by Sumit Shah, MD, MPH. I first met Diane during my 2-week stint as the attending physician in an academic oncology inpatient service. She was an elderly woman with snowy white hair, piercing blue eyes, and a razor-sharp wit, which came out periodically when she was not too exhausted to speak. Just 6 months prior, she was diagnosed with metastatic lung cancer and has suffered from every complication imaginable: blood clots, bleeding, recurrent pleural effusions, trapped lung, and pneumonitis from the very immunotherapy that she hoped would be her savior. Diane's daughter, Susan, was a fixture at her bedside. A nurse for over 30 years, she could not help but do what came naturally to her. Susan fiddled with her mother's nasal cannula until it was more comfortable. She repositioned her IVs with Tegaderm so they would not restrict her movement. She playfully adjusted the Foley tubing until that ever-persistent air bubble displaced every drop of urine into the Foley bag, and she would pinch her mother's skin to assess her skin turgor. Here was a daughter caring for her mother as only a nurse would know how. As I entered the room to greet them, Susan lowered her mask, revealing a look of exasperation, as if she was coming off a 12-hour shift. She explained to me that her father and Diane's husband, Jim, was also in the hospital on heart failure service, awaiting a cardiac device, his life supported by a single dobutamine drip to keep his frail heart pumping. Married for over 50 years, Jim and Diane, once high school sweethearts, were inseparable, with this hospitalization being the longest they had ever been apart. Susan's brother, Mark, was by their father's bedside, and the two siblings would exchange notes after their respective physician teams rounded, perhaps hearkening back to their younger days communicating over walkie-talkies. Any news of progress for one parent would be tempered by a setback with the other. And so it went for the next several days. It soon became apparent that Diane was becoming more ill. Her work of breathing had increased. The sensation of air hunger frightened her too much to even sleep at night, and she became less engaged on morning rounds. When we approached Susan and Mark about convening a family meeting to discuss their mother's goals of care, they relayed that Diane would not be able to make a decision without her most trusted confidant, her husband Jim, by her side. In what felt like a tiny miracle in a hospital begrudgingly regulated by COVID-19 protocols and visitor restrictions in the peak of the pandemic, we arranged for Jim to be wheeled over from the other side of the hospital to Diane's room. Mark positioned his father's wheelchair by his mother's bedside. There, husband and wife, in matching hospital gowns, embraced for the first time in weeks, each more concerned about the well-being of the other. It was an unusual and bittersweet reunion of sorts, raw and beautiful. Jim leaned over in a seated position to stretch out his feeble and ecchymotic arms, a byproduct of older age and years of blood thinner, as he cupped Diane's hands with his own. He would not let go. We explained to Diane that her body was showing signs that it was getting weaker, and we worried that time may be limited, perhaps several weeks to months, but it was difficult to prognosticate. We continued to say that in the event that her heart were to stop, or if she were to stop breathing, it would be a sign that her body was shutting down from the cancer, and that resuscitation would only be futile. We recommended focusing on comfort. Diane initially looked to her family for guidance. Although Susan and Mark wanted to give their mother more time to contemplate, Jim felt strongly that a decision had to be made in the moment. You never know what could happen, he said. Diane decided that she had been through enough. She just wanted to be comfortable in the confines of her own home. Jim shook his head in agreement, and so we placed a do not resuscitate order in her chart. Jim's eyes welled, but he maintained a strong grip as much as his weakened ventricle would allow. Diane was comforted knowing that her soulmate supported her decision and refocused her attention on the procedure he was to have the next day. As I walked into the team room the next morning, I was greeted by a forlorn look on the resident's face. Mrs. R's husband had a V-fib arrest last night and passed away. Even as a medical oncologist who confronts mortality on a daily basis, I was shocked. I had witnessed one of the most beautiful moments I had seen in medicine just several hours earlier, only to now learn of Jim's abrupt passing. I rushed to Diane's bedside to offer my condolences. She was surrounded by her children who were doing their best to replace their father's warm embrace. Diane was sitting upright in bed aghast, her widened eyes fixated on the wall in front of her, her mouth gaped open. She was stunned upon hearing the news. Her work of breathing had only increased, and soon she was taking in large gulps of air as if the room were slowly being submerged underwater. A few hours later, my resident called me. Mrs. R just died. As physicians, we often think that our treatments and basic physiology is what keep our patients alive. However, what happened to Jim and Diane, lifelong partners dying within hours of each other, puts that into question for me. Perhaps the will to live, or deciding to let go, is more powerful than the steroids, diuretic drips, ionotropes, transfusions, antibiotics, or even cancer therapies we administer. It would appear that sometimes, despite our best interventions, the human body and the human mind are capable of knowing when to shut down. This only makes our ability to prognosticate toward the end of life that is much more difficult. It is impossible to know how much of an impact Diane and Jim's reunion had on their eventual outcomes. Perhaps Jim came to peace after our discussion with the fact that Diane would no longer be suffering soon. Perhaps Diane decided that life without her beloved husband would lose its meaning. Modern science will attempt to explain the pathophysiology of the broken heart, but the bond and deep connection that Jim and Diane showed the evening before they both departed together is one that is more difficult to rationalize. And for that, I am grateful and humbled to have been a witness.
Welcome to JCO's Cancer Stories, the Art of Oncology, brought to you by ASCO Podcasts, which offers a range of educational and scientific content and enriching insight into the world of cancer care. You can find all of the shows, including this one, at podcast.asco.org. I'm your host, Lidia Schapira, Associate Editor for Art of Oncology and Professor of Medicine at Stanford. With me today is Dr. Sumit Shah, Clinical Assistant Professor at Medicine and Oncology and Medical Director of Digital Health at Stanford University School of Medicine. We'll be discussing his Art of Oncology article, The Will to Go On. Full disclosures for our guest will be linked in the transcript and can be found on the article's publication page. Sumit, welcome to our podcast.
Thank you, Lydia. It's a pleasure to be here. Thank you so much for having me.
It is our pleasure. So before we start to discuss The Will to Go On, I'd love to ask you a general question about what you read and what you're currently reading now and what you can perhaps recommend to our listeners.
Yeah, absolutely, Lydia. So when I'm not reading randomized clinical trials in oncology, I try my best to read for enjoyment, typically right before going to bed. I tend to gravitate towards work outside of medicine. So currently I'm reading All the Light That We Cannot See by Anthony Doerr, which is a World War II story as told through their eyes of a blind French girl and a German boy in France and how their parallel paths eventually intersect. Doerr writes so beautifully and uses language to create these very vivid scenes. It's really a remarkable masterpiece that's taken him, over 10 years to write this. So quite extraordinary and highly recommended to our listeners and readers.
Thank you. I love that book. I share your enthusiasm. Let's move now to your story, The Will to Go On. You describe an encounter with a patient, Diane, and her husband. During your 2-week stint, you say, as the attending physician in an academic oncology inpatient service. So let's start and unpack that for a moment. How do you envision that role in terms of your connection to patients? I've heard many colleagues who say that it's very difficult because they don't know these patients, they haven't cared for them. How can you introduce some humanism into that role?
Yeah, absolutely, Lydia. So we have several services that deal with just oncology at Stanford. And my favorite service is the teaching service, where we're working with residents and interns and fellows, strictly with patients who have cancer. It is a very emotionally charging month for our trainees. And a lot of my responsibility, I think, is actually keeping that dynamic and the culture of the team to be as positive as possible. So I have certainly a responsibility to my patients, which I think is really important, but really also to the trainees. And so I think it's incredibly important that we model good behavior. So that's what I see as a large part of my job, is really having these very difficult conversations with patients, for the most part, that we've never met, because they're often treated by their own primary oncologist, who's someone different than I. And oftentimes it's even more challenging, given that they're typically coming in with a disease that we may not be even familiar with, given that we mostly subspecialize at Stanford as well. So that can be very difficult to meet a patient that you don't know as much about about their disease. And two is that you don't know much about them as a person. And then to have to be the liaison between a patient's primary oncologist and what you think is best for them there in the hospital. But I do think that sitting by the bedside, maintaining eye contact with our patients, putting your arm on them is so important, not only for the patient to feel that there's still a connection with not just you, but their outpatient oncologist, but also for the house staff to see that there's so much about humanism in oncology that makes it such a special field.
So your patient, Diane, has metastatic lung cancer. You are a GU medical oncologist, so that is a clear example of what you just told us. And you tell us that she's now admitted to hospital, having suffered many complications of that same immunotherapy that you say she had hoped would be her savior. Tell us a little bit about how you interpret your role as a teaching attending and also as a communicator with families when you see patients who are coming in with toxicities from treatments and treatments that may end up being futile.
I think one of the more challenging aspects of our jobs as oncologists is actually seeing patients that have complications from their own therapies as opposed to succumbing from the cancer itself. I think that it adds a layer of responsibility and almost sometimes guilt that you may have brought this on. Obviously, these are not our intentions, but we have to be so humble that our therapies can be incredibly toxic. And we often talk about these drugs like immunotherapies, which are the brand new shiny object in oncology, where everyone is talking about it because it's on every single commercial out there. So patients really want it. But we sometimes mitigate some of these symptoms and these side effects that can really affect our patients. So, it's interesting in the outpatient world, we talk about these drugs as potentially life prolonging or potentially even life saving, but we see the complications, very closely in the inpatient setting. So we have to discuss and kind of realign expectations and make sure that our patients are now aware that these drugs do have toxicities, but hopefully we can try to overcome these toxicities and get you back to where you were before you came into the hospital.
So now let's go and meet Jim and Diane. Diane is your patient, but Jim is an important character in your story. They've been married over 50 years, and Diane is the one who is hospitalized with all the complications of treatment. And you talk about entering the room, and you use the first person. So were you alone, Sumit, or did you have an entourage? And I ask this because I've found, and I think it's important to also address the difference between walking in alone or walking in as a team leader. As you say, understanding that part of your role is to model behavior for your trainees.
I actually did have an entourage with me, and I feel that patients and families really appreciate that. I try to walk in last, typically when I go into a room, largely to empower the trainees to serve as the primary physicians. And when things get a little bit more challenging in terms of discussions that require a certain level of understanding of oncology, I tend to step into that situation. But I won't forget, standing in the corner of Diane's room, seeing Jim wheeled into the room, and just seeing how these two individuals just looked at each other so intently, and you can just see how much they missed each other based on the expression of their faces, and that's something will always stay with me. But it was quite an incredible moment.
So you call a family meeting because you think that Diane's prognosis is very poor, and you want to have a goals of care discussion. And so by what you call a tiny hospital miracle in the pandemic, Jim, who's also a patient in the hospital waiting for a cardiac device, is wheeled in accompanied by his son. Diane is there with her daughter, who's a nurse at bedside. And you have a family meeting, which is actually the celebration of this reunion and clear demonstration of their love. Tell us a little bit now, looking back, what actually happened in that meeting.
Yeah. So these meetings can be very difficult to navigate, largely because traditionally we're taught to ask these very open-ended questions to respect patient autonomy and have patients make their own decisions about this very sacred question about what would you want to have done towards the end of life. And these can be very, very difficult conversations to have, obviously. But I also feel that this puts an undue burden on a lot of patients who may not have as much experience as we do in understanding the consequences of these decisions. So for instance, especially this DNR discussion, I tend to have less of an open-ended conversation with our patients. So I tend to be very direct and offer my recommendation and then hope that the family would also be in agreement. And certainly we put those questions out there to them. And, 9 times out of 10, they are in agreement. I think it was also very helpful that their daughter Susan was also in healthcare as a nurse. So she was able to understand some of the implications of this. But these conversations can be very difficult in general. But I do sense that many times I actually get a lot of comfort after these conversations because they often go relatively well. And you can just see a sense of relief that's taken off the shoulders of our patients. That is actually very comforting to see.
So what makes the situation so special, and the reason probably, and I'm going to ask you this question in a few minutes, that led you to want to write about it and share this experience with your colleagues is the dynamic between the two partners, right? And it looks like Jim perhaps had been the decision maker, and Jim's input here was really important. And Jim wanted a quick resolution to this question. Tell us a little bit about how you felt watching that happen right in front of you.
It was quite extraordinary in a lot of ways because you could see that Diane was very much dependent on Jim. Prior to her becoming sick, she was, a very spry and spunky, elderly woman. But you could see that she really deferred to Jim in a lot of ways and her children to explain to her that they thought was best for her. And so when Jim was certain that they needed to make a decision right then, I actually was taken aback because I thought that it would take much longer, given Diane's ambivalence about the situation in terms of she was just really confused. She didn't know whether to, be DNR denied. She didn't know whether to pursue comfort measures to keep on going. And I think Jim's reassurance really helped her.
One of the things that made this meeting so special was that it appears that it was Jim's presence and his resolve to reach a resolution that moved the meeting along. And this is something that seems to have struck you. And you used the word in your essay that there was comfort in that. Can you tell our listeners a little bit more about how Jim sort of took the role to advance the conversation?
Yes, it was very clear that Diane was not going to make a decision without Jim. Not only did Diane's daughter, Susan, mention this, but Diane herself said that she needed to have Jim in the room if she were going to make a decision about both the DNR status and about overall goals of care in terms of moving forward with comfort measures. So when Jim came into the room, it was very clear that she looked right to him whenever these questions were asked to her about what she should do next. And you could just see that these two people knew each other so incredibly well. And I just felt that she almost felt that Jim knew her better than she knew herself. So we certainly want to respect patient autonomy, and we always wanted this to be Diane's decision. It was very clear that she was going to defer to Jim. And it was beautiful in a sense that Jim was so resolute because he made a very clear decision that he thought would be best for her, and she agreed. And after that, there was no going back and revisiting this question. It seemed that there was a burden that was lifted off her shoulders, and she was able to even breathe a little bit more comfortably after hearing from him. And that was a really beautiful moment to witness.
You have this beautiful phrase there when you say husband and wife in matching hospital gowns embraced for the first time in weeks. There's such a warm and there's so much love that just, you can even sense in the dialogue. So you leave the room and then what happens?
So we left the room, and I remember the entire team was talking about this beautiful interaction that we saw between two people. And then the next morning, I come into the resident room, and the resident looks at me incredibly forlornly and says, Dr. Shah, Jim died last evening. And I just couldn't believe it. I was shocked. I was in disbelief. We had just had this beautiful meeting and orchestration of getting two people together and witnessing that it was very, almost like a beautiful ceremony in some senses, and this reunification. And now to hear that Jim died the day before receiving a life-saving cardiac device was just so troubling. I think it raised like a number of questions and emotions in my head. One was shock and disbelief, as I discussed, but two was gratitude that we were able to arrange for Jim and Diane to have that final moment together. And then three, I was just so worried about Diane and how she would react to this news. So that's why I wanted to rush to her bedside as soon as possible to see how she was doing.
And so you did. Did you go alone? Did you go with a team?
At the time, I actually went alone because the team was still rounding with other patients, and I just felt an obligation to see her right away. So I rushed to the bedside, and it was very clear that she had already heard the news from her children. She was absolutely stunned, and she was in a delirious state. She wasn't able to verbalize, and she was just faintly moaning and staring at the wall in front of her. It was a very difficult sight to see. And for me in that moment, I wanted to offer my condolences, of course, but I also think that there's a lot of importance in allowing families to have time and space to grieve. So I try to make myself a bystander as much as possible, not make myself the center of this conversation. So I allowed them some time to process.
Yeah, witnessing is an important part of accompanying patients, right? As we're there, we're present, we're maybe silent, we're just there expressing our support with compassion. And then we get to the end of this story. Tell us what happened to Diane and how that made you feel.
So after Diane received this news, she was obviously in shock. She continued to have very labored breathing, but we just discussed her prognosis the day before, and we had discussed that her timeline would likely be measured in weeks or months, potentially, based on how she was looking. And as oncologists, we're conditioned to know when death is imminent, typically within hours or days. And she did not have that look, which is why it truly shocked me just to learn hours later, while we are in rounds, that a nurse paged us to tell us that Diane had just died. And again, the same feelings of shock and disbelief. How could this be possible just hours after her husband passed? I think, again, many questions surfaced. The first question as a physician and as, scientist is to think about, well, was this brought on by a physiologic response? Could the stress of the news precipitated a hypertensive crisis, which led to flash pulmonary edema and then hypoxia and arrhythmia, right? We tend to try to create a story in our minds about how could this have happened and rationalize this. Could she have had Takotsubo's cardiomyopathy, disease of the broken heart? Or was there something that's within her that told us that now is a good time for her to pass? And that's a question that I really struggle with for some time.
How did you talk about it with a team?
Yeah, I think, one of the fundamental struggles in our profession is balancing the ego that's required to take responsibility for another person's life with the humility to acknowledge that our therapies and our understanding of the human condition is very limited. So I think, when I was talking to the team, I felt that in this situation, I felt that no matter what we could have done medically for Diane in this hospitalization, either to keep her heart pumping or to, keep on perfusing her organs, she was going to declare herself, and that she decided that this is her time. So this is obviously very difficult for the house staff and for myself really to accept. You feel almost a sense of responsibility, but also just, you saw two beautiful patients getting together, and then 8 hours later, neither of them are around. And it was truly a heartbreaking scene. But I asked the house staff just to be kind to themselves and kind to each other, and also just try to appreciate the beauty in what we saw as well.
You write in your essay that this scene put into question for you, perhaps that the will to live or deciding to let go is more powerful than physiology, that there's something else. In reflecting upon what you saw, what you witnessed there, has that changed a little bit, how you approach the time that somebody lets go, or how much power the mind has over the body's ability to be in this world?
Yeah, I feel that it's really humbled me. I just feel that there are existential forces beyond our therapies that really determine longevity of life. And that it's made me realize that our therapies are very limited in their utility. And if a patient decides that they no longer want to keep going and they have come to peace with the fact that this is the end of their life, that they will make this decision. And we've all seen this as well in our own practices. The times that you come by the bedside of a dying patient, and just hours after they meet with you and their family, and you let them know that it's okay, you see that they pass. So it's an extraordinary thing to witness, and certainly a privilege. And this concept of a will to live is a fascinating one that that I read a lot about as well. That really inspired me to look deeper into this subject.
Years ago, there was a beautiful essay published in Art of Oncology by Steve Grunberg, and it talked about a physician who made a house call to a patient to basically allow her to die naturally. And he sat at her bedside, and whatever happened in that room led to her peaceful passing. So I think a lot of very thoughtful, humanistic physicians in our specialty have witnessed these moments, and they've been transformative, really. So my last question to you is, how did this encounter and this experience change you? And if it did, what do you now bring to the bedside or the next consultation that perhaps wasn't quite there before?
So this really inspired me to, dive in a little deeper into this concept of a will to live and really truly try to understand that. There's actually a psychiatrist that I read about that I believe that you actually pointed to me towards, is a psychiatrist named Harvey Chochinov. And he actually wrote about this concept of a will to live back in the late 90s and early 2000s. And his research was really at the crux of the death with dignity and the physician aid in dying conversations that were being had in Oregon at the time. And Chochinov was able to identify certain positive factors that reinforce a will to live, such as a sense of well-being, low anxiety levels, strong commitment to religion or living with a spouse. But unsurprisingly, he also found factors that erode the will to live. These include shortness of breath and physical suffering, such as pain. But there were also some existential factors that also led to an erosion of the will to live, including a loss of dignity or a sense of being a burden to others, which also was a significant risk factor. So when I'm putting this together for me, I tend to think about, are there things that we can mitigate, such as physical pain, shortness of breath, to potentially improve a patient's will to live? Or are these more existential? And are those things that I cannot control? And maybe I should just be more okay with that as well. And I feel if a patient has come to a certain conclusion, I feel more comfortable now, not trying to convince them otherwise. And my job is to reassure them and let them know that we're going to care for them and respect their decision. So I think that that's largely how this scene has really changed the way that I practice now.
And my really final question is, what made you want to write about this? And many people write to process and experiences, but then to share it with colleagues and with people that you've never met.
I actually remember going home that evening after hearing about both Jim and Diane, and I went home to my 3 boys and my wife. We were at the dinner table, and my wife asked me, "How was your day?" And I probably responded with a typical, "It was fine, pass the potatoes" kind of comment. And then I said, wait, no, let me reflect. And actually, what my day was not fine is actually I saw one of the most extraordinary scenes that I've ever witnessed in medicine so far. So when I told this to my wife, who's also a physician, she's one that actually encouraged me to write about it, largely for 2 reasons. One is to process, as you mentioned. It was very clear that this had a huge impact on me. But 2 is to remember this as a story. At the end of the day, our lives and our professions are a collection of stories. And this is one of the more remarkable patient stories that I've ever been a part of. So that was a big part of it. And then the question about publishing, I think, is an interesting one, especially this day and age, because you could either publish in a form like this, or you could also just tweet about it and get out to thousands of people within seconds, at the click of a button. But I think that, storytelling is so fundamental to the medical profession in a lot of ways. In a sense, we as doctors are really storytellers, and we hear and tell stories of people inflicted with illness, and we share this with others to teach and learn. This goes back to our days in training when we're sitting in the resident room and the chief resident asks you to share a case. essentially we're telling a well-structured story of a person who fell sick and using that experience to teach others. So I think by publishing, I'm hoping to share with the community of like-minded individuals to create a culture about sharing about medicine and to relate, and hopefully have people who can relate to my piece, reflect on it, and perhaps encourage them to share their own stories with others too.
Well, thank you so much, Sumit. This has been a lovely conversation. So until next time, thank you for listening to JCO's Cancer Stories, The Art of Oncology. Don't forget to give us a rating or review wherever you listen. Be sure to subscribe so you never miss an episode. JCO Cancer Stories, The Art of Oncology is just one of ASCO's many podcasts. You can find all of the shows at podcast.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.